Good afternoon. My name is Barbara Schneeman. I'm emeritus faculty from University of California, Davis, and I'm the chair, and my co-chair is Dr. Brandy Nguyen from Emory University. But I'm going to start the session today, first of all, to give a little bit of background about ILSI, who's sponsored this symposium, but also then to give you a little bit of context in terms of how what's happened recently with the National Academy of Sciences looks at science, but also as a way of thinking about how science relates to policy development. So these are my disclosures. My primary FASB organization is the American Society of Nutrition, and we always have to give our disclosures. And background that's relevant here is certainly my experience at the Food and Drug Administration with the Office of Nutrition Labeling and Dietary Supplements. So a little bit about ILSI for those of you who are not familiar with it. ILSI North America, or International Life Sciences Institute, is a nonprofit scientific foundation that advances the understanding and application of science related to the nutritional quality and safety of the food supply. It operates under a tripartite model, bringing together scientists from government, academia, and industry to look at issues and science that improves public health. It is important to note that ILSI does not lobby, conduct lobbying activities, or make policy recommendations, but rather focuses on addressing scientific questions of common interest across industry, academia, and government. So in terms of providing some context, certainly our session today to look at some of the physiological effects of sodium and potassium on hypertension is very timely. We just had the release in March of this year of a new report from the National Academy of Sciences, Engineering, and Medicine on new dietary reference intakes for sodium and potassium. And I just want to put that report in context. The original DRIs, or dietary reference intakes, were published in 2005, the electrolyte report from the National Academy of Sciences, using the DRI model that was developed in the late 90s, early 2000. And within the context of that model, it's possible for nutrients to establish an estimated average requirement. And once we know what the estimated average requirement is, then that can be used to develop a recommended dietary allowance, or an RDA, which covers the nutrient needs of most of the population. Now, in many cases, it's not possible to establish the EAR and thus the RDA. And so this model allows for what's called an adequate intake, or AI, that is an estimate of what meets the needs of the population. The model also includes a tolerable upper level, and when the 2005 report was done, the tolerable upper level, or UL, was just simply regarded as an intake above which the risk of an adverse event begins to increase. So for sodium and potassium in 2005, it was not possible to establish an EAR and thus an RDA. So an AI was developed for each of them. A UL was established for sodium, but not for potassium. And in 2005, the UL for sodium was based on increasing risk of hypertension. So that model has now been expanded. And we still have the DRIs for nutrient adequacy, which refers to the EAR, RDA, and AI, but the DRI for toxicity, or the upper level, now has a new definition, and it's based on a toxicity endpoint. And what has been added then to the DRI model is a DRI based on chronic disease risk reduction, or a CDRR. So this is a new DRI, and the report that was just released is the first time that the Academy has implemented one of these CDRRs. So if we look at, I'm just going to summarize the recommendations, and if in the panel we can always get into more detail if needed, but the DRIs for sodium and potassium in apparently healthy populations, and again, it's important to emphasize this is for healthy populations, not for individuals with disease. So the DRIs for adequacy, once again, the committees felt that there was not sufficient data to establish an EAR or an RDA for either sodium or potassium. The potassium AI, adequate intake that was developed, is based on the median intake in the population. However, the sodium AI was determined from experimental studies, and that was viewed as a better approach because obviously if we used the median intake, the sodium intake might be too high. It would be higher than where risk for hypertension increases. So it's not possible to use the median intake. The DRI for toxicity, and again, this is now toxicity, not chronic disease risk, that there was insufficient evidence to establish the UL based on toxicity risk. And the DRI for chronic disease risk reduction for potassium, once again, the committee determined that it could not establish such a DRI for potassium, but it could establish such a DRI for sodium, and it synthesized a DRI based on indicators for cardiovascular disease, hypertension, systolic blood pressure, and diastolic blood pressure. And I'm not going to go into all the detail of what the DRIs are, just to highlight in adults, and it's done for all age groups. I'm just giving you the values for adults. So for males, the DRI is 3,400. For females, 2,600 milligrams, and that contrasts to an AI of 4,700 milligrams from the 2005. So it's a considerable change in the adequate intake. For sodium, there's not that much of a change. The AI is viewed as 1,500 milligrams for adults, and now the 2,300, which in the 2005 was considered an upper level, it's now the chronic disease risk reduction DRI of 2,300 per day. So you should be consuming less than that. So just to summarize then, the DRI report for sodium and potassium, it updates the 2005 reference values. It creates the first chronic disease risk reduction DRI, and it gives a comprehensive review of the evidence for the relationships between intake and adequacy. And I think in the presentations in our session today, we're going to really hear more about the science, the evidence that is there, and how we can look at that evidence to make recommendations. Now, it's also important to keep in mind, how do these DRI reports get used? It's nice that they're a compilation of science and recommendations, but they are very important for policy development. So for example, any of you who are familiar with nutrition labeling, the nutrition facts on food packages, the DRIs can be used to establish the daily values that are used in nutrition labeling. They can be part of the evidence that's looked at in the review of the dietary guidelines for Americans, and that process is just beginning. They also can be considered by federal programs such as WIC, the Women, Infant, and Children Feeding Program. So again, it can refer to the DRI reports for the recommendations that might be useful in those programs. And generally, they do form a scientific base for public health initiatives to reduce risk of chronic disease. So it's a place where we bring the science together, make recommendations, and then policymakers can take advantage of that. So, this just summarizes the session that we're now going to be going into, and it's my pleasure to introduce my co-chair, Dr. Brandy Wynn from Emory University, who will be introducing the speakers. So, Brandy.
So we're really excited that all of you have come today. We have a really interesting 3 speakers who are going to talk a little bit about basic science as well as translational and some clinical developments as roles of potassium and sodium in the development of hypertension. So our first speaker is going to be Dr. Alicia McDonough from University of Southern California, and she's going to talk about the gaps in knowledge about the role of sodium and potassium in hypertension. And I want to be sure to mention, if you notice, there's a panel discussion at the end, so feel free to ask questions after each speaker if we have time, but definitely stay for the panel discussion where we'll be able to discuss all the speakers' information and policy information with Dr. Schneeman. Thank you.